My first guest is a mental health activist. She's one of those who campaigned for this bill to pass and consulted on its contents. Hawa Ojefo, good to have you on the show. Welcome.
Thank you, Sandra. Thanks for having me.
My second guest is a consultant psychiatrist. She's one of those who campaigned. She isn't one of those who campaigned for the bill to pass, but it's her field of work essentially. Dr. Frances Adiku, good to have you on the show. Welcome. Hello, Dr. Frances. Okay. All right, cool. Welcome. And then our final guest is the Senior Program Executive at Order Paper. He is, a guest who we met the first time last week, and Order Paper does a lot of work documenting what happens at the assemblies, the different assemblies. Temidayo Taiwo Siddiq, welcome to Eyes and Nays on Hard Facts.
Thank you, Sandra. It's a pleasure to be back here this week.
Yes, Lagos, join the conversation as well. 0700-993-993. Dr. Adiku, I have to come to you first. I have to ask first, why did the Lunacy Act take so long to change into what we're seeing now? Why did we have the Lunacy Act in place for so long? Were medical practitioners not worried about it? Did it hamper how you could do your job as a psychiatrist?
Okay, right. So the lunacy law, which was pre-colonial, or which was the colonial era, was pre-independence. That was 1958. So that was put in place, and I think there was a historical reason as to why that was needed. But we, as the field of psychiatry grew in Nigeria, we realized that that was outdated, that was inhumane. It really infringed on the human rights of people with mental illnesses. And we started campaigning for a change. And I think the closest we have gotten was when Senator Martins Yellow, sort of fought for a new bill, or fought for the new bill to be enacted. And that was in 2000, and then he was in Senate. And it was kicked out. And there are several tries, and finally we have the bill becoming an act. So it's not like we sat on our oars and we did nothing. We have been fighting for this. Have been, the Association of Psychiatrists in Nigeria have been, spearheading this for decades. And I think right now this victory is such a huge one for us because it actually protects our patients from the atrocities which have been melted out to them.
This new act says that it intends to preserve the dignity of the mentally ill. The old Lunacy Act seems to have viewed the mentally ill as dangerous or maybe even criminal. In what tangible ways does this difference in philosophy translate to how we treat the mentally ill, Hawa?
I haven't seen the actual law that was assented to. We all perhaps have the copies of the last one that passed the assembly, and sometimes there's a discrepancy between what passed and what gets to be assented. But I would say that, generally speaking, I really do hope that that's what the case is. That it is actually about protection of people who actually have mental health conditions. And the reason I say that is because when I testified on the National Assembly in 2020, the bill that I was testifying against, actually not for, was, a bill that it looked like the essence was the same, but was just dressed with new clothing, and so part of the things that we need to always, for us, we try to benchmark against is what are the international human rights best practices? What are the international commitments that Nigeria has made with regards to preserving the rights of people with disabilities, which, people with psychosocial disabilities or mental health conditions really fall under. So we're looking at and we're looking out for things like, have issues with regards to foster detention being stripped out of the law, have issues with regards to legal capacity to make their own decisions being stripped out of the law, like withholding legal capacity. Have we seen more on supported decision making, with regards to people that interact with mental health care? Are we seeing no restraints. A lot of times we talk about chemical restraints, but chemical restraints and physical restraints are not, the best practice with international human rights standards, and things like that. So those are some of the things that we're looking at, because it's one thing to have a law that has really fine writing, and it's another thing to really now look at, who does it really benefit? Does it really benefit people with psychosocial disabilities, or is it a room full of people who do not have psychosocial disabilities that are making decisions on behalf of people with psychosocial disabilities?
That's a very interesting point you make there, and I want to come back to it a bit, and I'm also curious to hear what Dr. Aduku has to say on that eventually. But let me come to Temidayo in a bit. Temidayo, in the Fourth Republic, we have had 2 failed attempts to repeal and replace the Lunacy Act before this success. What was different this time, Temidayo?
I think that can you hear me?
Yes, go ahead, please.
Okay, so I think that Awa touched a bit on one of the unique attributes of this bill, but importantly, if you ask me, 3 things that makes the bill largely stand out compared to what we've seen before. The first is that, I will just pick it up from where Awa stopped, and the fact that it guarantees that those receiving treatments, they have the right to participate in formulating their medical plans, and they cannot be have forced treatment, seclusion, or other methods of restraint. Common practices in mental health facilities without appropriate safeguard. Of course, we know that to a large extent, this bill also is heavy on establishing human rights protection for those with mental health conditions, such as banning discrimination in housing, employment, medical and other social services. So a case where people discriminate, someone with mental health illness, I can't give my house to that kind of person. I mean, it could be a serious issue for you if you do that. And then I think one very unique part of it, which I believe will come to later, is one of the setbacks that previous bills have suffered, and that's finance. So one provision of this bill is that it's establishing a mental health fund, as well as, again, the one I feel we'll also talk about much later, a mental health department in the Federal Ministry of Health, as well as a mental health assessment committee to protect stakeholders. So I think it's largely holistic, but the professionals you have in the house will be in best position to look at it from that point.
Lagos, if you just tuned in, hello to you. Good evening. This is a new segment on Hard Facts. I'm Sandra Ezekwesili. On this segment, we talk about the laws that are being debated at the state and national assemblies, the laws that pass the state and national assemblies. We also look at how these chambers perform their oversight duties on the executive. I've got 3 guests in the studio with me. Well, they're joining virtually. We're joining via Zoom, and you can watch us live on Facebook. Facebook is Nigeria Info 99.3, YouTube Nigeria Info FM. And my 3 guests today are addressing how the Mental Health Act will protect Nigerians with mental illness. Hawa says, well, we don't even know if the copy of the bill that we're discussing today is the copy of the bill that was assented to by the president. On that, I will come to Temidayo. Temidayo, so you shared this bill with me, and that's essentially what order paper does. Is this a gazetted copy? What we're working with?
I think it's a clean copy. What I can assure you is a clean copy that was sent by the clerk of the National Assembly to the president for assent. So, like Hawa said, I don't know if it's Hawa or your.
It's Hawa. It was Hawa.
Yes, Hawa. That sometimes
there are discrepancies.
Entering downfall the National Assembly to the president's table. Maybe some things may change. I want to be that, but we got around that this is a clean copy of the bill. You could see the title when I sent it to you. It shows clean copy. So
what does that mean for all of us who are novices about how these things work? What does a clean copy of a bill mean?
The clean copy means that it is that the final copy, and it means that it has the necessary work has been done. Typos have been taken out. Errors that would have come with draft and all of those other, when you reproduce the bill type and all of those things are taken out. So that's essentially just like it sounds to the layman. Clean copy is
clean copy. All right. You just heard the voice of a senior program executive at Order Paper. He's on the show with us. He was here last week. We also have a consultant psychiatrist on the show for me. She's also the head department of neuropsychiatry at the University of Port Harcourt Teaching Hospital. We also have a mental health activist on the show who is the executive director of She Writes Woman. I want to come back to a point that Hawa made, Dr. Aduku, and I want you to address that point for me. She says that, sometimes we have people who do not have psychosocial conditions making laws for people who do have psychological conditions. Do you think that it matters in the grand scheme of things, Dr. Aduku?
Well, it does. It matters. So, from what I've gathered for the process of this current act, was that what was related. You also have stakeholders who live experiences as part of the team. So it wasn't just a bunch of people who have never experienced this making laws for people who are living with conditions. So we have people who have stakeholders, basically people with health challenges, family members of people with mental health challenges, all coming together to, go through it and say, this is okay, this is not okay, why don't you look at this? And that's why we are able to address these particular issues.
Okay, all right. I have to come to Hawa next. Hawa, I know that you're wary about the bill we're looking at, but what are some of the specific ways what we're looking at improves protection of the rights of the mentally ill? Hawa?
I think the first thing I'll say is, coming from 2020 to now, the very obvious thing when you look at the bill is the change of language. And I'll have to applaud them for actually taking that in, taking our advice and suggestion, feedback very, very importantly. You would notice that in the bill, we're using human rights language as opposed to...
Yes, I was very impressed by the language, yeah.
Yeah, it was really good, and we really applaud them at least for that. Because one of the things that I definitely raised on the floor was that we want to ensure that this bill is not just a bill for medical practitioners, which is all well and good, but we want to ensure that it has a broader meaning. It's a health thing, it's a social thing, and it's for our entire country. And so the language is very important. So you would look at the language and you would not see anything like mentally ill in the language. So you see persons with mental health conditions. So that is a big one. So that also goes a long way in steering new conversations around, people with mental health conditions or people that interact with mental health care. So that's number one. The second thing is that we can now see in plain language is that indeed, people with mental health conditions are equal before the law, that their rights, their dignity and liberties are to be protected, at least from the version that we're seeing, absolutely it is spelled out. And I think that's really amazing because some of the things that we have to deal with in, whether it is state-owned facilities or traditional healing camps or religious centers, is that we see inhuman practices being carried out on people with mental health conditions. And that is something that, we frown at. That is something that really dehumanizes an individual, but it just falls short completely from our fundamental human rights as, people that live with mental health conditions. So that's definitely something. The third thing that I'll point out is that I believe in about one or two places, tops, the bill mentions supported decision making, which is a step in the right direction. And for people that don't know, supported decision making is a replacement, a human rights angle of what would typically be medical practitioners making decisions or family members making decisions on behalf of a person that has a mental health condition, as opposed to, the person making a decision but being supported by other decision, and so what we're seeing is more power back into the hands of people with mental health conditions, more autonomy and agency in making decisions that affect them, whether it is medical decisions or other types of social or socioeconomic decisions as well. The right to, use their personal belongings and things like that. The right to, Timidayo talked about housing and, work and all of those things. So I think that's a lot. Another thing that I'll definitely mention will be community-based mental health care. It mentions it, but I'm really eager to see what the national policy would look like in terms of implementation when it comes to community-based mental health care, because that is something that human rights is very heavy on. We need to start the process of deinstitutionalization. A lot of times, especially on this side of the world, we think, we need to build more psychiatric facilities. However, the human rights angle, and we've seen it being practiced in countries like Peru, for example, who have been able to, ensure that legal capacity is protected. That's number one. But we also see countries like Italy making very, very advanced, progress, development with regards to deinstitutionalization, removing people from institutions where, there's a lot of warehousing of inhuman treatment. There's a lot of, segregation and isolation and, just a lot of things that go on there. But putting them into the communities and allowing them to receive, social support or medical treatment or rehabilitation as close to home as possible within their communities and things like that. And so I think it's a welcome development, and I'm eager to see how that goes. So those are a couple of things that I feel like, are good steps in the right direction as far as the mental health law.
Dr. Duku, does she leave anything out? And in addition to that, I also want to ask, does this new act improve the ability of mental health professionals to deliver care?
I think it does. Right. So, following on what she said, if we are taking mental health to the community level, so what we're having is, as you said, the institutionalization, and so that's the integration of persons back into the community. It allows them employment, it allows them housing, it allows them better living conditions. The community that people with mental health conditions are like everybody else, and so that ends up reducing the stigma that people face, people who have mental health problems. So, and the current bill, what it does is that because it's promoting recovery, so it takes away. Previously, in the past, all you wanted to do was restrict symptoms, right? So you give medication, you bring the symptoms down, and as long as the person's symptoms are reduced, you've done something. But that's not recovery. Recovery is that the symptoms are down and the person is able to have a good quality of life. So it actually pushes us to go further in our treatment and our care of people that have mental health conditions. So we're not just thinking about restricting the symptoms, we're thinking about improving quality of life, improving employability, allowing them to make their own decisions. So it actually does improve the care that we ultimately have to give to our patients. So it also, and if there's recovery, then there's rehabilitation and come back into the society. So it also, so it also promotes for the implementation of the minimum standard of care. So it's not just enough to, in the Lunacy Act, you can pick someone off the streets, you can lock them up in a mental health facility and just observe them for 7 days without any treatment. That's so wrong. But a lot of places just do that. So now that's not acceptable in this new bill. So there has to be the minimum, at least the minimum standard of care for patients.
What would that be? What would that look like? Minimum standard of care. What would that look like now with this new?
Well, that depends on the condition.
Okay.
So it depends on the condition. So, for example, if you're talking about medication, for example, we have what we call essential medications. So the minimum essential medications that should be available must be available to treat mental health conditions. Okay. So for the facilities as well, it means that there has to be provisions of mental health medications, essential medications. There has to be training doctors who in mental health so that they can attend to patients with the minimum standard of care, provisions of medications, psychosocial interventions, all of that. So that's now is essential. So it also, and of course, as we have also said, it also facilitates community mental health services, and that's a big thing because according to the World Health Organization, mental health should be at the community level. We're not about building standalone psychiatric facilities. That's not what it's about. It's about caring for people where in the least restrictive environment, where they're most comfortable. So that's where community health services comes in. So, and with that, we as clinicians have to improve ourselves, have to provide these services. And of course, we have to put pressure on the government for the implementation of these services as well, because they're not currently programmed. Yeah.
Okay, because it's one thing to have a nice act, a nice law that, but it's another thing to feel the impact of that law, implement that law. Lagos, if you have questions, please go ahead and give us a call. 0700-993-993. Nigeria has finally replaced the Lunacy Act with a modern mental health act, and today we're looking at the process that got us here, what the new law says, how it differs from the colonial era law that it replaced. We've got WhatsApp available if you have questions. WhatsApp is 080-959-75805. Okay, we've got calls. 99.3, hello.
Sandra, good evening.
Good evening, welcome.
Lucky Lala.
Hi, Lucky.
This
Welcome.
law is a step in the right direction, but my...
Oh, that's unfortunate. Call us back, Lucky, if you can. 99.3. Sorry about that. Give us a call back if you can. 014657190. That's our number for women. Men, call us on 0700-993-993-993. I think one of the most important questions to be asked is which lawmakers were most instrumental in getting this bill passed? Temidayo.
All right. It's difficult to largely point to one lawmaker because of the process of lawmaking goes through a number of stages. But I think just as is in tandem with legislative practices, the bill is attributed to, the sponsorship is attributed to the chairman of the Senate Committee on Health, Senator Ibrahim Yahya Olori-Egbe, who's from Kwara State. So we would leave it at, to his credit. So we'll leave it at that. But like I said, this is a huge law. You heard Awa and Frances talk about how stakeholders were involved. So you can't really attribute the entire thing. But for the purpose of lawmaking and the Senator Ibrahim,
all right, thank you very much. Okay, we have a break coming up, but before we take that break, I have a question that I wonder if we can answer in 3 minutes, because that's all we have before the break comes up. And with this question, I want to come to Dr. Adukwu, because she's the consultant psychiatrist in the room. And this act prescribes standards of care in mental health care facilities. So, for example, it bans the use of restraints except under extreme conditions. What do you think about that, first of all? And
Are still used,
okay,
but said in very extreme circumstances.
Okay.
So in the olden times, you get patient in, and the patient comes in chains.
Okay.
It's like they're criminals. Trying to put a stop to that is quite difficult.
Okay.
But with this law, at least it's illegal to do that, except in extreme cases. And the extreme cases, if you read through it, keeps saying you require 2 psychiatrists independently make these decisions. And so I'm hoping that would actually help improve that. So I didn't get the second part because you are glitching a bit.
Oh, I'm sorry about that. Okay, well, that's my cue to take a break then. When we come back, I'll ask you the second part. I also want to ask Howard that same question that I asked Dr. Adukwu. So Howard, just think about your answer for me so that when we return, you'll share your thoughts on that. With this standard of care mental health care facilities that the Act is prescribing. Lagos, I'm Sandra Ezekwesili. You're listening to Eyes and Nays. It's a new segment on Hard Facts that focuses on state and national assemblies, what goes on in there, how it works, what the processes are, what laws are being debated, what laws are looking like they're going to be passed, the impact of those laws or potential impact of those laws on you, on your lives, etc., etc. Don't go away. This is Nigeria Info 99.3.
You go also get 10% extra on top every airtime recharge when you recharge for my MTN NG app.
Wait, Feso, you mean say if I recharge for money on my MTN NG app,
you get 10% extra airtime.
for evening, Uko?
10% extra airtime on top your recharge.
Wait, what do you call the app again?
My MTN NG
gig one time. Oh yeah, make I go recharge with my debit card. Make I follow collect 2 gig plus 10% extra recharge.
Terms and conditions apply. What are we doing today?
Thanks for calling Bastion
Since
HMO.
I signed up with Bastion HMO, I don't worry about hospital bills. I get access to top quality healthcare and still save enough for other things. They even help me pre-book my doctor's appointments. Bastion HMO also gives me access to over 1,700 hospitals and clinics with the freedom to switch whenever. I feel so in control of my finances and health.
Call 0800 Bastion or visit www.bastionhmo.com to purchase a plan that suits your needs. Bastion Health, the HMO that puts you in control.
Our country one better. Nigeria one better. Who go do one for us?
So people of Nigeria, they jolly for the better when one shell for we country. So as they ready to vote Asiwaju Bola Tinubu as the next president of Nigeria, I him get the experience where he go fit use take make our country better. People of Nigeria, for this and many other better things when in don't vocalize, it good make we all vote Asiwaju Bola Tinubu for president of Nigeria. Kashim Shettima as vice president. Vote everybody.
Some people say tech is the new coil, and others say tech is in the future. With ALX, tech is here and here to stay. ALX is your career accelerator built to give you in-demand global tech skills and access to a community that provides lifelong learning, lifelong networks. Register on www.alxafrica.com as the programs are fully funded for a limited period. Unlock possibilities with ALX.
Everyone is at the table for lunch. Mom is bringing in the jollof rice. And then...
John!
Sorry, Mom.
Hello? Can I order some jollof rice to be delivered?
Mama saves the day. Lunch is here.
Mom, I got some Coke too.
Just come and eat, Joe.
Cook up memorable moments because family lunch and an ice cold Coke make a recipe for wonder. Coca-Cola, real wonder.
My people, we bring to you here and now the Glow Festival of Joy promo.
It's a life-changing prize galore from Glow.
A stadium full of gidigba prizes to be won.
20 brand new houses,
24 brand new cars,
100 generators,
200 sewing machines, 1,000 rechargeable fans,
and thousands upon thousands of other unbelievable prizes.
This fun center in the Glow Festival of Joy promo. Buy up to 20,000 naira data during the promo period and you could win a house. And if you recharge or load data from 500 naira to 10,000 naira monthly, weekly or daily, you stand a chance to win a brand new car plus other great prizes.
Don't just sit around scratching your chin.
Dial *611# now to enter and win. Terms and conditions apply.
Glow Unlimited.
Flour Mills of Nigeria PLC FMN is committed to creating an integrated supply chain that can provide stakeholders with complete access to high-quality, fair-priced products. FMN continues to provide the needed support to its business partners through capacity development and the establishment of a sustainable route market structure. Through its R&D strategy, FMN has created an agile route-to-market structure that allows for seamless product mobility and delivery from the point of processing to the end users. From farm to table, the group has created a resilient and sustainable supply chain structure. FMN is committed to Nigerian complete access to high-quality products from cultivation to final consumption, while accelerating food processing, value addition, and the sustainable development of its supply chain. The group is passionate about feeding the nation every day and is a source of livelihood for millions of Nigerian families. FMN, feeding possibilities, transforming lives.
Welcome back to your number one talk, news, and sports station. This is Nigeria Info.
Welcome to Eyes and Knees on Hard Facts. I'm Sandra Ezekwesili. This is Nigeria Info 99.3. How will the Mental Health Act Nigerians' mental health conditions? I have three guests on my show: a mental health activist, a consultant psychiatrist, and a senior program executive at Order Paper. My mental health activist is Howell Jafo, who is also the executive director at She Writes Woman. Our consultant psychiatrist is Dr. Frances Aduku, who is also the head of Department Neuropsychiatry at the University of Port Harcourt Teaching Hospital. And then our senior program executive at Order Paper is Temidayo Taiwo Siddiq, other papers work is essentially to keep track of what happens at the National Assemblies. Like I've been saying since we started, this show is all about our legislative chambers on
from what gets to the Ministry of Health. So with this in place, and if it's been implemented, there will be reforms of mental health facilities. There will have to be improvements. There will have to be research and and definitely there has to be. I mean, if you go around psychiatric facilities, for example, some of them are in the most deplorable states. So for some of these places, there needs to be a total overhaul of what is actually being practiced. Because if there isn't any law that says, there's a minimum standard of care, then there's really nothing you can hold the government to say you have to improve the services that we offer. But with this, we can now actually push for something and say, look, you have to change these things, because everything that has been done to improve mental health care has been done at the hospital level, so now it has to come from the government level, and it's a law that has to come in place. So if you're going to say there isn't going to be physical restraints, then it means that there has to be provisions for alternative forms of caring for patients. And because we that work with patients, we know that there is a need for some form of restraint. Okay, so things like what we use what we call chemical restraints. So not really. In the past, you have to sedate the patient and make sure the patient is sleeping. But there are better things where you can just calm the patient down while they're able to have conversations and converse with you. So these things have to be made available now because, we can determine that is the minimum standard of care, and therefore those things have to be provided.
How you're the mental health activist in the room. I wonder what you think while listening to Dr. Duku speak.
It will be interesting to see it implemented. I think a lot has to be done with regards to reorientation of the medical practice, like the medical practitioners that work in mental health care, with regards to human rights in mental health care. It is not impossible. Yes, indeed, standards are the least restrictive environment as possible. And so I guess for me, my concern is really who gets to determine what that is. And it's always that bit of ambiguity that leaves room for a lot more exploitation that we bargain for. When we're having these conversations, I believe we have them with good intentions, right? It's going to be, except when it is absolutely necessary. But who gets to say when it is necessary? It still falls on medical practitioners, right? And so on some level, I feel like there's so much more work that needs to be done with the bill or with the law, whether it is working with human rights defenders, whether it is looking at international best practices. Currently, my organization, She Writes Women, is putting together good practices across Nigeria and perhaps African continent as a reference document also for, everybody that works within the mental health space for us to see what other countries are doing. And I don't mean, when I say other countries, a lot of people think US and UK. No, they don't have they are not good references for human rights and mental health care. So we're looking towards Peru and Italy and, some other countries around those sides of the world that share more commonalities with Nigeria as opposed to, the US and the UK. And so I'm still wary about it really as to who gets to say what. Because ultimately, one thing that I'll definitely say was different about, passing of this bill was that people with mental health conditions for the first time got their voices heard in a way that was significant. So one of the things that we always say that it's not enough for you to just say, oh, there's a seat for a service user, because that's usually the language, a service user. All well and good, but international best practice, international human rights law is that there must be robust and sufficient consultation of people with mental health conditions or people with disabilities, generally speaking, when it comes to these issues. So I would say that's definitely something. And so for me, I would like to see a bit more of that, going forward, what that means for us as people that interact with that care. And ultimately, the idea is that we need to shift the power. Historically, the power has been in the hands of medical practitioners. And not to say that they're bad people or anything. It's just that at the end of the day, the world has changed. Research is showing more things about mental health, not looking at it purely from a biomedical perspective, but from a psychosocial perspective as well. So it's less about the medicalization of mental health and more about exploring it from a social perspective as well, and trying to balance that out as opposed to everything now gets down to a medical condition. So, for example, would say rather than one of the things that was in the previous deal was police officers having the right to like restrain somebody and take them away if they perceive, that was the word, that they have a mental health condition. I was like, what does perceive mean in a country where mental health is not talked about enough, where we don't know enough about mental health? What does perception mean? And again, those ambiguities leave so much room for exploitation and inhuman treatment, and it still keeps the power where the power has been pre-colonialism, pre-independence, which is in the hands of medical practitioners and law enforcement, and we look at that constant, you only see it when it comes to mental health. You don't see other health conditions being medicalized in that way, or now going through law enforcement in that way. And so it's how do we try to redistribute that power into the hands of people that actually have mental health conditions, so that we can come to the table empowered and on an equal basis as other people. We're not saying some things should not happen. We're just saying that if you're not going to do it for other people, then why do it for us?
Dr. Duku, what do you think?
Okay, so yeah, I do agree that that there are some ambiguities, but the whole idea is to start the process, and then as you start, you tweak it, and then you say, okay, this isn't working. How do we improve this? How do we say this better? So that's there, and the good thing about this, as she has said, was that we're taking the power away from it's no longer a paternalistic kind of thing where, so a patient comes in and we say, do this. It is more of a discussion. The whole idea, when we saw the part of the police having some form of control, we also were like, no, this can't really, that leaves a lot of room for abuse. And then, of course, who tell me who has a mental health problem? With someone that hasn't got any form of training, and then so there is a lot of room for improvement. There's a lot of room, but at least it's in a step in the right direction. What we're doing is we are putting the patients first. We're putting people living with these conditions first. We're looking at it from their point of view. We are saying, okay, how does this affect you as a human being? How does it affect your rights, your discussions? So how does this affect your ability to work, to live, to all of that? And that's, for the first one, that's actually being brought to the forefront. If you go back and you look at, if you read the Lunacy Act, and where mental illness is described as lunacy and idiocy, and looking at where we are now, and looking at the struggle and the fight, to change that definition, away from magistrates and police officers, and say, okay, it is a condition, it's a medical condition, it's hypertension, diabetes. So we should have a conversation as to how one gets treated. But the peculiarity about mental health and mental disorders is that at a point in time, along the spectrum of the illness, there is loss of insight, there is poor judgment, and this is what brings about the stigma. So at that point in time, who makes those decisions?
Because that's also a question I had while Hawa was speaking. And I understand the advocacy for let the person with the mental health condition make a lot more of their decisions, etc., etc. But there are also times where the condition prevents them from making the right decisions for themselves. But it also, leads us into the room of, who determines what is the right decision for the patient, one way or the other. So I really want to hear what you think about that. In conditions where the patient cannot make decisions that can it even be objective, or is it really subjective? What is the right decision for the patient and what isn't? I don't know, Doc.
So now the whole idea of two separate mental health practitioners, or should make independent decisions based on the patient. So, because there is a point, and this is for someone like me, I've been doing this for over 10 years. There is a point when that person in front of you is unable to make a decision concerning their health because because the insight isn't there, the judgment isn't there, and that is the peculiarity about mental health conditions. And it's at that point that people tend to bring in abuse and all of that. So And it is at that point where you hear even, family members who are meant to be protective of this person, they exploit that point at that point in time. So we get to live and see the practicality of all these things. So at that point, who makes that decision? At that point, as the mental health professionals, we have to make that decision because we are unbiased. We're unbiased. We really have nothing to gain or lose.
I like the air quotes of unbiased.
Because there's nothing. I can't say that for everybody. So I'll put it like that.
Yeah.
So and then after that point, you now what we do now, even before this, is that after that point, once the patient starts getting better, insight starts returning, we now sit down with them, have a discussion. And sometimes you hear the funniest things. You hear. I'll give an example where a man was brought in chains, handcuffs, and everything, and was said to have been under the influence of substances and has been behaving irrationally and has a mental health condition. And of course, the first thing I had to do was, take up those chains. It was like, oh, he's going to, beat you, and I said, just take it off first. And so I had a conversation with him, and we both came to an agreement that, okay, yes, he needed to be in hospital. And once he got stable, and we wanted to discharge, it was like 2 weeks. And the relatives were reluctant. They were like, oh, just keep him for a bit. And we have to probe further. So we got the social workers, go and probe, and realized that, that was the time they were sharing the property and the first son. So at that stage too, so you see, sometimes even the family members too, take advantage of the situation. So that's why, I'm happy that, this bill has been passed, and those little peculiarities are being taken into account.
Consideration.
Exactly.
Which is why, and Hawa, I'm going to come to you with this question. Temidayo, I know you're still in the room. Thank you for hanging with us. I'm going to come to Hawa with this question. I'm wondering, Hawa, does the creation of a single 5-person mental health assessment committee at federal level risk creating a bottleneck for assessing cases of involuntary admission? Because I saw that in the bill and alarm bells went off in my head. How?
Absolutely, you're spot on. We're creating bottlenecks, and let's not even take out the politics from the entire thing. A lot of times when we see committees, you start seeing departments, or you see councils, or things like that. We all know what's really going on when we look at it in a political perspective. I mean, we're in Nigeria, we know what's really going on. So yes, indeed, bottlenecks, but even much more than that. And just to pick on what Dr. Francis was saying, really, and one of the things that we're trying to prevent really is, I love that you asked who gets to determine what the right decision for the person is, and for us, it's not, best practice is not the medical practitioner, because like the air quotes already suggested, that's also very risky as well. We see a lot of conniving that goes on in that regard. And we don't even think it should be family members either. Again, the same problem, conflicts of interest are always in the picture. So I'll tell you something that we've done as an organization for years. We have actually been doing supported decision making, and I think that's something that we need to explore a bit more. Where again, the individual is the one that makes the decision. And I know a lot of times they'll say, oh, but, and I'm like, still, the individual is the one that makes the decision. However, there are independent parties, impartial parties that help support the person to make the decision. So, for example, people would call our helpline, right? And they'll say, oh my gosh, I've been taking this medication for a long time, and I've been this, and now they're saying that they want to admit me, and blah, blah, blah. And they would tell us all this entire story, and we're like, that's interesting. Or they're panicking, maybe they're what you would call hysterical, they're crying, they're, in what you would typically feel like is very irrational. Or family members will say, oh, I've been trying to tell him, or we're trying to tell her she's not agreeing, and we want her to go by all means, and things like that. Well, okay, fine, so let's talk to the person. And we talk to the person, and we're not advising. So that's the thing. We're creating a picture for you. We're breaking down your options for you. We're telling you actions and consequences. And then ultimately, we're like, okay, so what do you want to do? Because when you take this is what happens. When you take this is what happens. Who matters to you? Okay, my family matters to you. You don't want to let them down. Oh, you don't want to do this. Okay, so how can we build in that bit of information into your decision-making process? Ultimately, it happens. It is possible to support people to make their own decisions, and so I feel like there's so much more that can come from it. I foresee possibly even other bills with regards to supported decision making, even being created just to somewhat frame or legalize to legalize supported decision making in this regard, right? So yeah, that's really what I see.
Okay, Temidayo, does the creation, and again, it's a question I asked Hawa earlier on, but maybe you have a different view. Does the creation of a single 5-person mental health assessment committee at federal level risk creating a bottleneck for assessing cases of involuntary admission? Because that's a part of this act that I saw.
Except for perhaps limited understanding for those who work in the public space. But we do know that what the Federal Ministry of Health and indeed federal, if you like, quasi-judicial committees like this, what they do is to provide direction and policy direction for certain things to take place. So I would expect that we would have this replicated in states, state government, because Nigeria runs a federal system of government. Yes, this is the national law at this time, but I think that it will not be out of place for other federating units, especially the states, to take this up just as we have with other laws.
And domesticate it.
Yes, domesticate it, take parts of this so that to a large extent it reduces whatever bottleneck will come with implementation. I want to refer you to the work that the mental health assessment, part of the objectives of creating that committee. So they hear appeals. A person says, I was unjustly treated when I was in a particular facility and things like that. So you want to imagine that in the 774 local government areas, you would have to bring the case to just one committee. That's a hell of, forgive my language, that's a whole lot of hard work to be done. And then what if it happens during the period of public holiday where these persons are not available? How do you address the issue? So when you look at it from that prism, Sandra, I think that this has provided inspiration. It's not a perfect law yet, and as it is with every law in Nigeria, it will have the tooting stage, and then we really hope that those stop gaps that have been put in this law to address some of these things, the state authorities or state governments would take on these things and use it as a way to ensure that citizens in their own domain, those who have mental health conditions, are also treated in line with what this law is trying to achieve.
I feel like we're going to need to come back to this law at some point in the future, because there's so much that we haven't even touched on. So, for instance, the Act bans sterilization. I want to talk about how much power the Federal Ministry of Health has over the way state health ministries address mental health. I want to know, for instance, if primary health care isn't, purely a state and local affair. I want to talk about the creation of a Department of Mental Health Services, for instance, within this law, and we're already out of time. So I'm thinking we'll have to do like a part 2 of this conversation if my guests are willing and available when it's time to do part 2. But Dr. Aduku, I want to hear from you, because at the end of the day, you are the boots on the ground. Do we have a problem with this single 5-person mental health assessment committee thing?
Well, it's on paper now. So we haven't implemented it to know what difficulties are going to be. But do I foresee difficulties? Yeah, I foresee difficulties because, if you're looking at a population of 180 million people, of which about 20% have some form of mental health challenge, and mental disorders on their own maybe is about 10% of the population. That's about 18 million people split across the country. And then, of course, a percentage of these people, maybe 1 to 2% of them, would need involuntary admission. So how are 5 people going to attend to millions of cases? Of course, in the practicality of that. But, Let's start and see how
Let's start and see how it goes. Okay. Thank you so much, ladies and gentlemen, for joining me on the show today. Lagos, you have heard from Dr. Frances Aduku. She is a consultant psychiatrist from the University of Port Harcourt Teaching Hospital. She's also the head of neuropsychiatry there, the head of department of neuropsychiatry. She is, by the way, also the chair of the early career psychiatry section of the Association of Psychiatrists in Nigeria. She's one of the very few we still have around, so we're grateful to have her in Nigeria and on the show. They're all leaving us. We couldn't have enough, and now they're all leaving. Then we have our mental health activist, Hawa Jefo. Hawa is also the executive director for She Writes Woman. Thank you so much to both of you for joining us. Senior program executive at Order Paper, Temidayo Taiwo Siddiq. Thank you so much for your time this evening.
Thank you.
Thank you so much for having us.
Thank you so much, Sandra.
Lagos will take a break. We'll be right back.
Hey, my name is Alex. I've been a content creator for a while now, and I always try to innovate to keep my audience entertained.
And I want to assume that you would run because I want to give the listeners context for the conversation.
In 2019, you were running mate to Atiku Abubakar. What did you learn then that you will not repeat this time?
Yes, when is the president coming out to address us?
There's a few things. One, I have a burden and a passion for young people.
The fact that you have elected a man does not mean then you begin to order him around. The president will do whatever is good for the country at any given time.
Mr. Adeshino, isn't the president responsible to the people?
What should the next president do to root out stakeholders who are complicit?
You fire those. Those that need to be fired are fired.
It's looking like a brand new Chelsea, attacking with so much fluidity. And what can you say about that, Martin? I know you follow Chelsea quite closely.
I live close to the Chelsea training ground. That's what you mean by that. I'm not